Assalamu alaikum everyone. In this video we will discuss chronic kidney disease. What is chronic kidney disease? It is irreversible deterioration of renal function over years. So both biochemical and excretory functions of kidney will be deteriorate. This syndrome is known as uremia. So there is high prevalence in diabetic patient, hypertensive patient, the patient with vascular problem, or the interstitial diseases of kidney or glomerular diseases. There will be chance of chronic kidney disease. The prevalence is approximately 10 to 20% in glomerular disease, 20 to 30% interstitial disease, and 20 to 40% of patients of diabetic have the chance of chronic kidney disease. So what are the signs of the CKD? So these main signs are yellowness of eye, pallor, pulsus paradoxus, brown line on nail, and bruises on skin. Patient will be chronic diabetic, hypertensive, anemic. The first symptom usually the nocturia. Nocturia is usually first symptoms. When the GFR is decreased 15 milliliter per minute per 1.73 meters square of body, there will be breathlessness, tiredness, and fluid overload. When further deterioration of the GFR is further decreased, there will be pruritus, anorexia, nausea, vomiting, and hiccups will be there. Anorexia, nausea, and hiccups are present. When very advanced CKD, there will be deep respiration known as cosmal breathing. In cosmal breathing, there will be metabolic acidosis. That's why there will be deep respiration in order to expire more and more carbon dioxide outside the body. So this is known as cosmal breathing. There will be also muscle twitches, fits, drowsiness, and coma. And so these are the signs and symptoms of CKD. What are investigations? The investigations are urea and creatinine level, urine analysis, electrolytes level, PTH assessment, and albumin level, and full blood count. Progressively increase in urea and creatinine level of blood. Urine analysis, there will be hematuria, proteinuria, if it is secondary to the glomerular disease. This is present, there is increased risk of progression. The will do electrolyte level, in which we will see hyperkalemia and acidosis will be there. PTH assessment, there will be renal osteodystrophy, in which renal osteodystrophy dystrophy, in which there is osteoporosis of the albumin level will be decreased due to malnutrition, inflammation, and nephrotic syndrome. Similarly, full blood count, there will be anemia. Okay, these are the investigations. In management of CKD, we will monitor in the renal function, which will be done every 6 months with third stage of CKD. The monitoring is done in order to assess the success of therapy. So we will monitor in the progression of hypertension, proteinuria, and osteodystrophy, anemia, and hyperkalemia, and acid-base disorder. We will monitor all these levels. The second one is we will decrease the rate of progression of the CKD. So we will give patient antihypertensive medications. The target will be 140/90 with CKD with no albuminuria. In patient with no albuminuria, we have target of 140/90 albuminuria, 140/90 blood pressure. Similarly, our target for the moderately elevated albumin, for proteinuria, we will reduce the proteinuria by ACE inhibitors. So we will prescribe ACE inhibitor in order to decrease the proteinuria. The second one is the renal replacement therapy. In renal replacement therapy, we will do dialysis or transplantation of kidney. Now, in order to treat the complication for urea, we will give dietary advices, in which when decrease in protein diet, there is decrease in urea production. Similarly, for potassium, we will advise decrease in intake less than 70 millimole per day. Also, we will prescribe diuretics. For acid-base disorder, when NN gave metabolic acidosis, and we will give bicarbonate. There is more than 22 millimole per liter, we will prescribe bicarbonate when H ion concentration is more than this. And similarly, for anemia, we will prescribe iron supplementation, and for renal osteodystrophy, we will give dietary advices, dietary restriction of phosphate, and we will give phosphate binding drugs, and we will also do parathyroidectomy. Parathyroidectomy is also done. If patient no success, then we will give cinacalcet, which is calcimimetics. So these are the main management of CKD. Thank you.